Skin diseases. Oh, okay. This is pretty painful. I really don't like these lectures, by the way. Yeah. But I try to keep it simpler for you guys so it would be useful. Hopefully somebody will use this one day. I use it every once in a while, but skin diseases are actually fairly important because actually it's the biggest organ in your body. It's the one you can see, too. So it's actually pretty important. And when you work in clinical, you can see a lot of skin because you're going to be doing a lot of surgeries that involve removing skin lesions sometimes. You're taking care of, if you're working in day surgery, you'll be taking a lot of patients out with malignant melanoma. So understanding the skin is actually important. Okay? When you break it down, it basically breaks down into different layers, the epidermis and dermis. Okay? The epidermis is made up of the stratum corneum and the stratum germinatum, okay, which is the basal cells, which are underneath. The stratum corneum, of course, are not living cells. They're just really basically dying, and they're dry, and allows to keep you dry in the sense that it's like an outer coating on you that prevents water from leaking in and water from leaking out effectively. The only thing that allows water to leak out is through the perforations, which is, of course, part of your sweat glands, okay, and where your hair cells are at. The dermis is the important structures where all the nerves that are living cells are at. It has connective tissue in it, which is important for stability of the skin. So let's break it down. Let's break it down into different parts. If you have inadequate connective tissue, you develop diseases that slough off your skin. One of these is called epidermolysis bullosa. Kind of easy to understand. It's the epidermis that's lysing off, and it's causing bubbles to form. See? You don't have to memorize it. Just remember the word. It's a hereditary disease. It's the skin and mucous membranes. It can be broken down into three types: simplex, junctional, and dysmorphic. The simplex is usually the epidermal layers are fragile, defective keratin, and defective basal epidermal cells. The junctional are more severe, causes a rarely or survive beyond early childhood. You get severe blistering, and they don't get scarring, so it's like having a continuous burn. And it causes, it's from the defective basal lamina. So the tight junctions that hold the next layer above it, isn't there. The dystrophic are defective collagens and anchoring fibrils. It causes severe scarring, including what's called pseudosyndactyly, which means that you actually lose your digits because of excessive scarring. Microstomia, which means that you have a very small mouth opening because of the amount of scarring that gets you around the mouth, and esophageal strictures. So what you see is this is your actual epidermal layer broken down. Okay, keratinized squares. This stuff is completely dry. This is actually becoming drier as it's moving up. Okay, and then this is your basal epidermal cell. Okay, and this is the one that's the simple one. Okay, and then you have your junctional, which attacks the basal lamina, and then your more dystrophic, which is down here in the dermis. And that one's more severe in the sense of scarring because that's where the scar tissue develops, not up here. That's why the basal lamina doesn't really have any scarification, and neither does the simplex. So this is what you get with the epidermolysis bullosa. You start getting basically any kind of friction will cause blistering. Okay. Now I've taken care of people with this. This is a very significant problem. If you put a blood pressure cuff on these people, they'll blister completely their arm. It's really bad. So what do? The answer is you put cast padding. Put cast padding around their arm and then put the blood pressure across the top. The cast padding shifts a little bit enough that it doesn't allow the actual blistering to take place. But you're also very careful, never grab these kids and pull them with their skin. Okay, you always put them on a sheet and pull them with a sheet. Meaning there, you got to be careful that you spread out their weight evenly when you're pulling on the sheet. If you pull on their arm, their skin will literally slough off. It's not something you want to see. This is the simplex. You can see it begins to break down the skin, and you can start getting heavily keratinized skin as a consequence. This is the junctional. This is much more severe. This is why they die. They literally have like second-degree burns that never heal. They continuously keep shedding their skin. It's not a good way to go. It's very painful. This is dystrophica. This is the severe scarification that you start losing digits. Okay? And this is what happens to their mouth. This is a nightmare intubating these kids. You rub the tongue, you slough the tongue right off. It's not a good thing, okay? It's very, very difficult management cases, okay? You really don't want to put these kids to sleep. Unfortunately, they come in for scar revisions and plastic surgery stuff. So you do have to intubate them. A lot of times we're very, very cautious and put extra, like when you intubate them, if you're going to use a straight blade, we put lube on the edge of the blade. That's something we never do. But in these cases, you want to lube everything up so it slides without minimal grabbing. And then you're very careful on the way you lift. You don't do jerking motion. You very gradually lift. You get minimal movement and get the airway visualized. But they can be difficult to intubate. Yes? The LMA? The glide scope would be, that would be fine to use. That would actually be preferable to use. You just have to put the lube in the front of it so it smoothly enters the mouth. I've done fiber optics on kids like this. The LMA is notoriously a bad idea, okay? Because when you slide it in, it'll slough off the mucosa, something I would prefer not to do. So be a little careful with that stuff. Some people say, oh, this is a good LMA case because you're in, but the outside is just as bad as the inside. I mean, the outside is just like the inside. If the skin is sloughing on the outside, it's sloughing inside the layers inside the mucosa of the mouth. And it's that fragile. The other thing that's epidermolysis bullosa is associated with many other diseases. Some of them autoimmune. You got porphyria cutaneous tarda, amyloidosis, diabetes, mitral valve prolapse, hypercoagulable states, also associated diseases. Perioperative, you want avoidance of trauma, shear forces like I just told you about. Okay? Minimize airway instrumentation. Okay? Airway concerns include immobile tongue, esophageal strictures, and microstomy. Pemphigus is the next disease process. It's an autoimmune disease that attacks the epidermal cell surface. Okay? It also has 50% oropharyngeal involvement. It's associated with other forms of autoimmune diseases such as myasthenia gravis, lupus, Graves, autoimmune thrombocytopenia purpura. So this is an autoimmune process, definitely. There's two types. One's more severe than the other. Pemphigus vulgaris is most common and has the highest incidence of oral lesions. So there's risk of malnutrition because people have so much pain that they won't eat. And then Pemphigus folliculus, which attacks mostly the skin and hair. Treatment includes immunosuppressants, which is going to be steroids and the anti-chemotherapeutic agents. What pemphigus looks like is that it attacks down here, the dermal layer, okay, depending on which one you're looking at. Okay. Pemphigus follicularis splits here, the upper layer, and if you look at the vulgaris, it splits down lower. It's much more severe. This is folliculus, and this is the one that actually you can see it's at the hair area. That's where the hair would normally come out. That's where it splits. This is the vulgaris, much deeper. Pemphigus is perioperatively, you got to look for fluid and electrolyte loss through the bullae, especially the vulgaris. Oropharyngeal bullae can also develop on you, so you got to be careful. Psoriasis occurs in about 3% of worldwide population. It's epidermal DNA synthesis is 4 times than normal, so they tend to get symmetric lesions. And there's different kinds of psoriasis. There's a guttate, inverse plaque, pustular, and erythrodermic. Please don't memorize that. It's just a dermatological thing. What we're looking for is what is psoriasis. And it looks like that. It's a hyperkeratinization of the skin. It's nothing that is going to cause you to die, but it's going to disfigure you if it's in the wrong place. Okay? A lot of people don't like the way it looks, of course, and they cover up as a consequence. They're usually wearing long-sleeve shirts while everybody else is wearing short-sleeve shirts. And they usually wear turtlenecks or they're wearing something to cover up their neck. Okay? Thank goodness most of the time psoriasis doesn't affect the face as much because of the higher oil base in the face. Usually this occurs in areas that have low oil base, so back of the elbow, okay, forearms, okay. So we think that it's a little bit protective to put oil or the oil being secreted in the skin. This is erythrodermic psoriasis. This is much more severe. And then you have guttate, which is a post-streptococcal rash. And then inverse psoriasis. This is an area that's highly wet, and that's normally not where, that's why it's called inverse psoriasis, because normal psoriasis is in areas that are dry. In this case, it's the reverse. This is found also in patients in their perineal area as well. This is actually a little bit uncomfortable, to say the least. It's red and inflammatory, and it is uncomfortable. It's almost like having a constant rash. I had this just a week ago when I was canoeing for 12 hours underneath my axillas, and it was not fun. So I can imagine having this constantly, it would be really uncomfortable. The other thing that also is a problem with them is they try to put any kind of underarm deodorant. It exacerbates the condition. So it's not very comfortable. Psoriasis typical treatment is topical Coles tars, and what you're doing basically is you're putting an external layer covering the skin, and it basically keeps the area oiled because it forms an interface, so the oil that normally is being secreted by your skin is not leaving. Topical steroids will also be used, and things like methotrexate and cyclosporin for widespread use. In the old days, this used to be part of treatment. In a lot of patients, they would go to what we call baths. For some reason, people of Italian origin seem to have this, Roman origin seem to have more of this frequency. And maybe it could explain why they have so many baths and stuff like that, because maybe it was more prevalent in their population. It still holds true to this day. Mastocytosis is a mast cell hyperplasia, which accounts for 90% urticaria pigmentosa. Systemic forms of mast cell accumulation in the bone, liver, and spleen. It leads to massive degranulation and almost like an anaphylactoid reaction. So you really have to be careful with these people because you got to avoid histamine-releasing drugs. Atrocurium with this person with mastocytosis could be lethal. Cutaneous mastocytosis is seen like this. These people just get hives everywhere. Atopic dermatitis is a cutaneous manifestation of systemic allergy. It's evidenced by pruritus, which is irritation, dried scaly skin, and eczematous patches. You have urticaria, which can be chronic. It occurs in about 15 to 25% of patients in the U.S., and it's unknown cause, about 2 to 1 ratio for female to male. Physical urticaria is usually caused by physical stimulation, skin wheals, itching, angioedema. That's what I showed you the other day. When you just do this on your skin, you'll form a skin wheal, and that's physical urticaria. Okay, you can see it's already breaking out. Pretty cool. You can see the red line form, and this causes histamine release in the cutaneous area. So that means that you usually have more, which is what's called symptomatic dermatographism, which is the next layer, which is light stroking the skin, causes bright red flares and pruritus, okay, but no angioedema. And you get these kind of urticarial hives developing. Angioedema is more severe in the sense that it causes degranulation of the mast cells, and that causes airway compromise. So it's the next step above. This is just skin, but then if it gets into if the mast cells degranulate into your vasculature, you get wheezing and you get airway compromise. If you have somebody with angioedema and history of urticaria, really don't tolerate ACE inhibitors very well. They have a higher predilection developing severe angioedema. The other thing you want to do is you want to avoid histamine-releasing drugs in these individuals. This is what angioedema looks like. If you don't deal with this fairly quickly, what's occurring in the mouth is also occurring in the throat. These people do respond to epinephrine and antihistamines. Urethral multiforme is a recurrent attacks of macular bullous rashes that's induced by viral or hemolytic strep infections, neoplasias, collagen vascular disease, or drug reactions. Okay, so this is a target lesion. There's 2 types. There's Ian Minor and Stevens-Johnson syndrome. We all have seen, how many people have seen Stevens-Johnson syndrome? Almost everybody's seen it, yeah. It's bad. Usually when you hear about it, everybody in the hospital comes over to see, because it's a terrible, very terrible complication of antibiotics usually. The skin literally will slough off the whole patient in that situation. and they become a burn victim at that point. In the minor, 80% of cases are less severe, self-limited, versus the Stephen Johnson is severe. It's usually a drug reaction leading to high fever, tachycardia, tachypnea. Rash can also involve the airway and the lungs, and can be treated with corticosteroids, but the biggest thing is stop giving the drug. This is erythema multiforme. This is a very minor form of it. And let me show you what this looks like. No, I didn't have a picture of it. Daggone it. I thought I had it. Well, Stevens-Johnson syndrome looks like a second-degree burn patient. It can be pretty severe. Scleroderma has a high population here in Naples, as well as in Miami. The reason being is that people with scleroderma also have very bad cold tolerance. They usually don't know why, but they've naturally moved themselves towards Florida or the Phoenix area. So there's actually two areas that have high populations of scleroderma, which is one is in Arizona and the other one's here. I don't know why in Arizona, because I do know it gets cold there, I understand, right? I mean, who's from Arizona here? Nobody's from Arizona? So there's, okay. How many people have been to Arizona? Is it cold there? It gets cold there? Never? Or wait, so it never does get cold there. So that's why everybody says go there. Okay. All right. I thought it got cold there because it's desert, but I guess not. Yeah. Okay. All right. That's something I learned anew. I thought it would get a little colder being up there, but all right. What's that? Oh, they do have snow up there? That's what I thought. But not for very long. Naples never gets cold. We only had snow here once that I know of. It sprinkled dust, and they said it was snow. I said, that's not snow, that's dust. It melted before it hit the ground. But they said it was snow. The mangroves did notice it. So anyways. Scleroderma is a progressive systemic sclerosing. It's an autoimmune connective tissue disorder. There's limited in the diffuse. The diffuse is of course, going to cause end-stage death, which is going to cause cardiac heart failure and respiratory problems as well. That's your diffuse. Your limited usually affects the fingers and face, and associated with other autoimmune disorders, including CREST, Raynaud's, esophageal dysmotility, sclerodactyly, telangiectasia. That's all part of the CREST syndrome. These are all the associated syndromes. It's all autoimmune diseases. So anything you see scleroderma, think autoimmune. This is what they look like. Okay, their skin is actually fairly pretty because it looks almost porcelain-like, and that's the pickup. If you look at their face, they have this almost like a porcelain doll appearance to them. Okay, and if you look at their hands, you'll see that it looks like it's very tight, and it actually is. And eventually, that tightness begins to affect the blood supply to the fingers. And you start losing digits possibly, and it causes a tremendous increase in afterload, so it becomes a problem for the heart. So you get hypertension and things like that. The other thing that the person will develop is almost like a mouse face. Their lips will narrow down, and their nose will sharpen up. So they'll have more of a mouse-like appearance. Okay? Usually what you do is you ask the person's picture when they were 25 or 30, and when you see them in their 40s or 50s, they've already changed dramatically, significantly. Okay? It's a slowly progressive disease. Unfortunately, there's no way to stop it right now that we know of. Organ system involvement includes non-pitting edema, taut skin, myopathy, arthritis, and also there's avascular necrosis of the femoral head also going to take place. Nervous system, we get compression-related neuropathies. Okay, sometimes you'll have to have back surgeries on these individuals. Cardiovascular, they get small vessel coronary disease, myocardial fibrosis, dysrhythmias, pulmonary hypertension. Telangiectasias are evident, and you also get Raynaud's, very commonly seen in scleroderma. Lungs, you get diffuse interstitial fibrosis, which is one of the leading causes of death because it leads to pulmonary hypertension. That's usually what ends up causing right heart failure in these individuals, and they don't do well. Kidneys, they get into renal failure, and they get into hypertension in the long term as well. GI, they get hypomotility syndromes, they get GERD, dysphagia, bacterial overgrowth, and pseudo-obstruction process. Perioperative, you've got to worry about airway narrowing. Airway telangiectasias may also be a concern. Hypertension, vasomotor instability, Response to cold environments is a big issue, so you got to keep them warm. They also have decreased pulmonary compliance, as you can imagine, from the pulmonary hypertension and the increase in interstitial fibrosis. And they have a higher risk of aspirating. And they may be more difficult than you think to intubate. They don't appear to be when you look at them initially, but when you actually put the blade in, it doesn't seem like it moves. The skin is almost like taut in them, and you can't move things around. So you got to be sort of aware of that ahead of time. They don't slough, though. Their skin doesn't slough off. It's just super tight. Okay. Then you have a more rare disease called pseudoxanthoma elasticum. Okay, this is a hereditary disease of elastic connective tissue. They get visual disturbances and vitreous hemorrhages because the collagen's too soft. It tends to be hyperelastic. They get xanthoma-like lesions in the neck, axilla, the groin, and they get GI bleeds. They can sometimes get a coronary artery disease and endocardial calcification, dysrhythmias and valvular involvement, including mitral valve prolapse, mitral valve regurg, things like that. Ehlers-Danlos syndrome is a more worsening than that. It's an inherited defect of collagen synthesis. These individuals always have joint hypermotility, fragile skin, they get arthritis, they rupture the hollow viscus or blood vessels easily, and so these people will be coming in multiple times, usually for perforated ulcers or something like that. They get higher incidence of developing pneumothorax, mitral regurg, okay? And there's a tendency to bleed excessively with minor trauma. You can always pick up an Ehlers-Danlos syndrome, though, easily. Usually, you see them as kids. It's one of your friends that grabs the skin and does this with it, and he pulls it, and you see like his skin doesn't seem to keep going, and you can't even do the same. So you show it off to you, and you go like, look what I can do. I'm going like, yeah, we can't do that. And that's because they have collagen that's not as thick. So they have hyper-extensible skin. You should wonder if that's where they thought about, the Fantastic Four or something like that, one of those guys who would extend it forever. That would be an Ehlers-Danlos syndrome kind of patient. Okay? It's basically defective collagen synthesis. Okay, so then you have what's called polymyositis, okay, which means that you have multiple inflammations of the muscles. Okay, idiopathic multisystem inflammation of skeletal muscle and cutaneous manifestations. Okay, it's an inflammatory, which is why it's itis. Okay, and it has about a 5-year mortality rate. It's sometimes also associated with about occult neoplasms as well. Dermatomyositis appears like this. You have these like xanthomas that develop in the skin like this. When you start seeing this, you got to think of yourself. The person before this was perfectly okay, and all of a sudden started developing this, and then you got to think maybe they have an occult cancer. Which is, if you have 20% incidence of occult cancers, you better start looking. Usually the place to look for this is in the liver, because it usually doesn't present until it's actually metastasized beyond the liver. So it's a GI tract tumor, like a small bowel tumor. It doesn't present until it gets past the liver. So at that point it's metastatic, which is, again, not a good outcome, as you can imagine. Again, you can see the dermatomyositis that affects the elbows as well. It's different than psoriasis. Psoriasis will thicken. This will actually develop almost like this redness inflammatory process. And also under dermatomyositis, you get a heliotrope rash, which is hopefully this is understand what a heliotrope rash looks like. Okay, butterfly rash. Okay. Again, telangiectasias will develop in these individuals as well. You get proximal muscle skeletal weakness, dysphagia, which means they have an increased risk for aspiration. They also have left ventricular dysfunction and conduction defects, and again, have the coexisting malignancy associated with this. It's also associated with other autoimmune diseases like lupus, rheumatoid arthritis, scleroderma. Sometimes it can be treated with corticosteroids and immunosuppressants. As you can imagine, if this person has an underlying cancer and you miss that, and you give them this, what's going to happen to their cancer? Let's see it spread as fast as it can. Okay? So you got to make sure before you start giving these immunosuppressant drugs and steroids that the person doesn't have underlying cancer. Abnormal response to muscle relaxants may be evident in these individuals, and non-triggering anesthetic techniques when CK is elevated, so it's kind of controversial. Some people are concerned about it. I've taken care of many people with polymyositis and then never seen them trigger to MH, so I don't know. The book said it was controversial. I've taken care of 20 of these people, if not more, I've never triggered anybody, so I don't know. Lupus, is a chronic autoimmune disease. It has anti-nuclear antibodies are present. That's really, we doesn't really know if it's the cause of the pathogenesis or rather it's a result of it. So it's unclear. It may be exacerbation by spontaneous or induced infections, pregnancy, surgery, or steroids. It can also be induced by stress, believe it or not. Lupus can be seen in people that have severe psychological stress. And again, it's not clear if it's the lupus that's unmasking the psychological stress or rather the psychological stress is inducing the lupus. Sometimes you can see it from drug-induced medications, anticonvulsants, things like methyl-dopa, penicillamine, or can also trigger it. Lupus is diagnosed usually with anti-nuclear antibodies, which in 95% of these patients have it. 3 out of 4 clinical signs that I just described before. Usually the anti-nuclear antibodies, malal rash, thrombocytopenia, serositis, and nephritis, and clinical manifestations caused by deposition of immune complexes or direct effects of autoimmune antibodies. So it can basically attack everything in your body. Classification of at least 4 of the following. Got a malar rash, discoid rash. You have increasing photosensitivity than if you have oral ulcers. Arthritis, serositis, which is inflammation of serous glands. You have renal involvement. Leukopenia can also be in the lymphopenia, and you get hemolytic anemias and thrombocytopenias. And of course, your anti-nuclear antibodies. Clinical manifestations is that people become psychotic. They may have neurological impairment, psychiatric problem disturbances. Arthritis may also develop heart, lung problems, kidneys, liver, neuromuscular problems, and cutaneous. So it attacks pretty much the whole body. Just show me what isn't attacked. That's the easiest one to remember with lupus. It can attack everything. In arthritis, it occurs in 90% of patients. It attacks the hands, wrists, elbows, ankles, but usually doesn't attack the spine. But really the pain that you see these individuals in is out of proportion to their physical signs. And it tends to be episodic and migratory. And the other thing that you can get is you'll get AVN, which is avascular necrosis of the femoral head, or condyle, which leads them to have a hip replacement in those individuals. You can also have vascular pathology, essentially, and so you get cognitive, mild, to 1/3 of the patients. They get psychological, they have mood changes to psychosis, can be frank, and have atypical migraines and aseptic meningitis. Cardiac-wise, they can get a pericarditis with effusions, myocarditis, which leads to conduction defects, tachycardia, myocardial dysfunction with congestive heart failure, and your valvular involvement involves non-infectious endocarditis, which is called Lehman-Sachs endocarditis, which is, I've seen this. One of my first patients that I took care of as a fellow was a young lady that apparently she died, unfortunately, upon us. But she had severe lupus to the point that her EF went down to 5%. She had severe cardiomyopathy. So lupus is not a benign process. You don't want to get this disease. Pulmonary also can lead to pulmonary lupus pneumonia, which is a dry cough, dyspnea. It can be a very profound hypoxemia, and it leads to a restrictive lung disease, but that's usually later on. That's not very the acute phase. The acute phase is more the infiltrative process. And you get shrinking lung syndrome, and these people usually, when you put them on a ventilator, they have very high peak inspiratory pressures. They also will get chest pain on breathing, which is called pulmonary angiitis, and lung hemorrhage is going to take place, and one of the leading causes of death of lupus is pulmonary hypertension. Renal may also lead to renal failure, including glomerulonephritis, proteinuria, and hematuria in these individuals. Liver can have abnormal LFTs in about 30%. Neurovascular-wise, you get proximal muscle weakness and increased creatine kinase, which may make them more likely to develop problems when you give them succinylcholine, so it's kind of controversial. Immunologically, they also have increased risk of thromboembolism because they have antiphospholipid antibodies, which makes it more reactive to form blood clots. They also have leukopenia, which increases the risk of developing infection. They have low complement levels because they're wasting them all. They get splenic dysfunction, thrombocytopenia, hemolytic anemias, and a lot of times they'll have elevated PT-PTT, and they'll have false positive syphilis tests, which is, of course, something that you don't want to be diagnosed with when you don't have it. Cutaneous-wise, you get this butterfly rash, malar rash, that's the way it's called. Photosensitivity, these people have patchy maculopapular rashes on the upper trunks and exposure to sun. Okay, airway is always what we care about. With lupus, you get cricoretinoid arthritis. So you can have a risk of a retinoid dislocation with intubation. And what I'd recommend if you're doing an intubation on this is put the smallest tube possible in these individuals. They also have a higher risk of developing TMJ disorder. So when you're doing this, try to be careful not to super lift. These people do not have to have their head lifted off the bed to intubate them. Okay? You really want to avoid that kind of technique if you were taught that way. The less trauma you make, the better it is for the patient. And you wouldn't want your head lifted off the bed. Put your patient in sniffing position beforehand. That way you don't have to lift their head off the bed. Okay? So just sort of things that I think are good practices that, you know, if it was me, I hope that somebody else would take care of me properly so they wouldn't hurt me. Okay? And these people can be hurt very easily by pushing a little too hard. The TMJ is, and these people are, the actual joint is breaking down. So if you extend it too much, you can dislocate them. And I've seen that. You have a dislocated jaw coming out of the operating room, and it's not very comfortable. You can't talk. You just like, you know, it's like it's completely dislocated. And how do you take a jaw and put it back in? What you do is you push it, so you both your fingers on the posterior molars, and you push it straight down, and then you let it slide back. It slides right in. The thing is, if it goes into masseter spasms, it won't slide back in. You'll hardly be able to open up the mouth. So in that situation, you have to induce the patient back, give them succinylcholine usually to break the masseter spasm, and then undo it and push the TMJ back in. You really don't want to do that if you want to avoid it. Let's put it that way. Okay? And there's a good chance that if you continually dislocate somebody like that, you can get avascular necrosis of that joint, just like you get avascular necrosis of the hip, which will then need that they'll have to have a TMJ replacement, which is not something, it's not a small surgery. Treatment, symptomatic, usually it's non-steroidals. Steroids are given for the more severe ones, or immunosuppression for very severe cases. Sunscreen and also some of the anti-malaria drugs seem to help as well for some of the dermatological manifestations. And that's it, folks.